Welcome to The Explainer. Today, we're diving straight into one of the most intense, high-pressure situations you can face in an emergency room, a patient who just can't breathe. We're going to break down how you approach acute dyspnea step by step and turn a chaotic scenario into a clear, manageable process. So, picture this. A patient is rushed in, they're panicked, and they say those exact words to you. Right away, your adrenaline starts pumping. And the first, most critical question you have to answer is this. Are they having a panic attack, or are they on the verge of true respiratory failure?
Before you even think about what's causing it, you have to figure out if there's an immediate life-threatening danger. This is not the time for a long, detailed history. This is all about survival, right now.
Okay, so we immediately jump to the ABCs. This is your absolute foundation. First up, A is for airways. Is anything blocking them? Are they choking? Simple but crucial. Then you move to B for breathing. How fast are they breathing? Is it too fast, too slow? What's their oxygen saturation on the monitor? And finally, C is for circulation. Is their heart racing? Is their blood pressure tanking? That's how you know if they're going into shock. All right, these are the big flashing warning signs you can literally see. Cyanosis, that bluish tint on their skin and lips, means they are desperately low on oxygen. And the inability to speak in full sentences, that's a huge red flag. It means they're using every single bit of energy they have just to take a breath. You also want to look for what we call tirage, where you can see the neck and chest muscles straining. That tells you their main breathing muscles just aren't cutting it anymore. If you see any of these, you know the situation is absolutely critical. So, once you've started some initial support, maybe gotten them on some oxygen, now you can begin that focused interview, the interrogatoire. Every single answer is a piece of the puzzle. And hey, for any of you med students out there prepping for a clinical exam, this part right here, this is gold. Mastering this is absolutely key. And the very first thing you're going to ask is about the onset. It's such a simple question, right? Did this hit you all of a sudden, or has it been building up? But wow, the answer can dramatically narrow down the possibilities right from the get-go. Because the answer to that one question, it's like a fork in the road. If it came on suddenly, just brutally out of nowhere, you've got to be thinking about a major event, a blood clot in the lungs, a collapsed lung, or maybe a sudden backup of fluid. But if they say it's been getting worse over a few days, well, now you're thinking about something chronic flaring up, like COPD or asthma. Next, you start digging for those specific risk factors. You're not just making small talk here. Every single question is aimed at a specific diagnosis you have in the back of your mind. You're hunting for clues. And this is how you start connecting the dots. They tell you they have a known heart condition. Bam. Acute pulmonary edema jumps to the top of your list. A long history of smoking. You're thinking COPD. And what about that classic story of a long plane ride or recent surgery? That should make alarm bells for a pulmonary embolism go off in your head. All right, so we've got their story. Now it's time for the physical exam. This is where we get to be detectives, using our own eyes and ears to find objective clues that either back up what we're thinking or, tell us we might be on the wrong track. And what you hear with that stethoscope is just so revealing. You hear that high-pitched whistle? That's wheezing, which tells you the airways are tight, like an asthma or COPD. And crackles, that sound like you're pulling apart Velcro, that points to fluid in the lungs, a classic sign of acute pulmonary edema. And what if you hear nothing, just silence on one side? That is a super ominous sign. It almost always means a collapsed lung. So after you've gathered all that info, the history, the exam, now you can build what we call your differential diagnosis. The key here is to focus on the big, scary stuff first. The top 5 life-threatening causes you absolutely, positively cannot afford to miss. And here they are, the big 5. You've got acute pulmonary edema, pulmonary embolism, a really bad asthma attack, a COPD flare-up, and, believe it or not, diabetic ketoacidosis. These guys are common, they're severe, and getting one wrong can be, well, catastrophic. Your whole initial game plan is built around finding or ruling out these heavy hitters. But hold on, we're not done yet. Our detective work isn't over. To really nail the diagnosis and prove our case, we need hard evidence. And that means turning to a few quick, essential tests. When it comes to acute shortness of breath, you have 3 best friends: a chest x-ray, an arterial blood gas, and an ECG. Think of it like this. The x-ray is your picture,
The blood gas gives you the cold, hard numbers on how they're really doing, and the ECG checks for problems with the heart. Okay, look at this. This is a classic X-ray pattern you have to burn into your memory. You see these fluffy white shadows fanning out from the middle of the chest? They call them butterfly wings for a reason. And when you see that, it is a huge clue for acute pulmonary edema. You're literally seeing the fluid that's filling up the lungs on film.
Now here's another dead giveaway. See that dark, empty space on the side? No lung markings at all. That's air that's escaped and is now just floating in the chest cavity, squishing the lung. You can even see the sharp line of the collapsed lung itself. This is the textbook picture of a pneumothorax. And this X-ray really shows you the long-term damage that severe COPD can do. The lungs are just so overinflated from all that trapped air that they're physically squishing everything else. Look how they've pushed the diaphragm down, making it totally flat. And see how the heart looks long and skinny? Kind of like a teardrop. These are all classic signs of chronic air trapping. So after all that investigation, what's the big takeaway? What's the core process that needs to be second nature? Just an automatic reflex when that patient comes in gasping for breath. It's this 4-step process, your clinical automatism. Number 1, evaluate gravity with your ABCs. Number 2, give oxygen, but do it carefully, and we'll get back to that. Number 3, order your urgent tests, that big 3. And number 4, stabilize the patient and start treatment based on what you find. This system, this is your safety net. It keeps you and your patient safe. And that brings us to one last really critical thought. I said to give oxygen prudently. See, in a patient you think has COPD, just cranking up the oxygen can actually be dangerous. It can make things worse. Why is that? Understanding the answer to this question is fundamental to safely managing one of the most common emergencies you'll ever see. It's the perfect reminder that knowing the why, the physiology, is just as important as knowing the what, the steps to take.